We're going to wrap up. This has been a great discussion. Before we conclude this peer exchange, I'd like to ask each of you to provide some final insights based on what we have just covered. Solange, I'll put you on the spot first. Any final parting thoughts?
Yeah, I think we've been developing what we aim to call, and we like to call, precision oncology. All these drivers that we are describing just move forward, frontline in naive patients, targeted therapy. It's amazing. But beyond that, we can treat the other patients who are not characterized with such a tumor with new, very interesting drug, which is immunotherapy. My note here will be that we still don't deliver precision immunotherapy. We struggle with PD-L1, we still don't know how to implement TMB, and we end up giving a triplet to all patients. So I think we have been going to precision oncology for drivers. We need to go to precision oncology for immunotherapy, just in order to spare money and create accessibility to all the patients.
Need for biomarkers, good point. David?
I would say for me, I'm really impressed. I'm quite happy of the benefit of the immune treatment before chemo and radiotherapy in the stage 3, because I think we were trying to improve this population, and particularly some of these patients can be cured by the treatment, and particularly this population might develop some metastases, and clearly the durvalumab brings a benefit. So I'm quite happy to have something efficient to propose to this population, to this patient, and so that's why we need probably nowadays to look at how to better select this population. I'm not completely agree to select this population according to the PD-L1 status, as it will be done in Europe. I'm not agree to select and not to treat patients PD-L1 negative and to not give them access to durvalumab. So this is something we might discuss. And the second thing, for the metastatic disease, immune treatment, completely agree, a huge benefit. We should keep in mind not only to look at the PD-L1, but again to look at the molecular status for the patient before to start the treatment. And just be aware that it's not immunotherapy for everybody. It might be immunotherapy. If you have a molecular alteration, you should privilege to go to the specific targeted therapy. So that's why, again, we need to have the view PD-L1, and we need to have the view of the molecular alteration of the tumor before to decide what is the best treatment for the metastatic disease.
Okay. Sanjay?
Well, you know, we're living in fantastic times, aren't we? I mean, it's so exciting to be a lung oncologist at the moment, and it's great to be able to offer all these amazing treatment options to our patients. I mean, who'd have thought 10 years ago that we'd have such great options? I think, you know, one of the key learnings of recent years is, you know, as you've said, is to really get a proper comprehensive molecular analysis of the patient, so you know what the key drivers are, you know what the PD-L1 status is, we might even know what the TMB status is, to allow us to be making the best decisions for the patients up front.
Final thoughts, Suresh?
I think we can all say and agree that we're truly in the era of personalized therapy for lung cancer, metastatic non-small cell lung cancer. Biomarker-based selection of treatment is reality for every patient. We have to test the patients for markers, specifically the driver mutations, and for PD-L1 now and hopefully TMB soon. But individualized therapy is here.
Yeah, exciting times. So thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.